The following podcast is part of a certified educational activity titled Achieving Consensus on Modern VOD SOS Management, a Guide to Disease Recognition, Classification, and Treatment in Adults and Pediatric Patients. Access the entire activity and complete the post-test at peerview.com/KAS860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Mitchell Cairo from New York Medical College. Welcome to this educational activity on veno-occlusive disease, also known as sinusoidal obstruction syndrome, where we will explore the recent development of a clinical consensus devoted to modernizing the approach to diagnosing and determining disease severity. I'd like to begin by looking at the spectrum of VOD and the medical impact of this serious disorder. So as you can see from this slide, VOD comes in many shapes and forms, ranging from subclinical VOD, where we actually can't make the diagnosis, progressing all the way to mild, moderate, and then ultimately severe, but still treatable. And unfortunately, as I will illustrate later in this talk, some of these cases end up being fatal. Now, the incidence of VOD following hematopoietic stem cell transplantation varies by both the type of transplant, as you can see here, autologous transplant versus allogeneic transplant, where there's a significantly higher risk of VOD in the allogeneic stem cell transplant setting. And there's also a difference between children and adult, and to some extent, a difference between the intensity conditioning, as seen to the right of this slide, where myeloablative conditioning in children has a much higher incidence of VOD than reduced intensity conditioning, which seems to parallel myeloablative conditioning risk in adult recipients. With that background in mind, let's move forward and discuss the nature of the risk factors for the development of VOD or SOS. So we divide risk factors in patients post-hematopoietic stem cell transplant into three buckets or three categories. One is patient or disease related, the second is liver related, and the third would be transplant related factors. Now the last one, the transplant related factors, they can be modifiable, and I'll discuss that in just a minute. So let's talk about the pre-transplant unmodifiable risk factors. They kind of break down into two buckets. One is risk factors associated with 3 to 10 times the incidence of VOD, and those that are greater than 10 times the risk of developing VOD. In the former, age is a risk factor. Patients with high iron loads as manifested by hyperphatinaemia, patients with pre-existing liver disease, those that have been exposed to CMV that are CMV positive, certain diseases like thalassemia, CML, immunodeficiency, and a few other specific conditions, all have been associated with 3 to 10 times the risk of VOD. On the other side, however, there are some conditions that are associated with over greater than 10 times the risk of VOD. Those include patients who have elevated bilirubins before they come into transplant, and then more recently, patients who have developed disease where they require immunotoxin therapies with either prior gemtuzumab ozogamicin or prior inotuzumab ozogamicin. These patients have more than 10 times the risk of developing VOD. Now shown in here is some updated data that shows in some series gemtuzumab ozogamicin, antibody directed against CD33, has up to a 37% risk of developing VOD in patients who go on and get a transplant. And in patients who receive inotuzumab ozogamicin, which is an anti-CD22 immunoconjugate, you can see here in one series the risk of developing VOD in those that went on to transplant was up to 27%. Now, age can also be a risk factor, as shown in this slide. an analysis of over 13,000 patients who developed VOD that was performed by the CIBMTR, you can see here that a very young age has a much higher risk of developing VOD, and that seems to go down over time based on age. But certainly the infants have a huge risk of developing VOD, and that's well known by the pediatric transplant community. Now, there are other factors associated with children besides age that are associated with VOD, and many of them have to do with the underlying conditions. In this slide here, as we outlined in a paper that's just coming out in the British Journal of Hematology, hemophagocytic lymphohistiocytosis, or HLH, osteopetrosis, neuroblastoma, some solid tumors like Wilms tumor and rhabdomyosarcoma, juvenile myelomonocytic leukemia, or JMML, and then, of course, hemoglobinopathies such as sickle cell disease and even thalassemia. Now, there are modifiable risk factors, and those are transplant related. So as I showed you earlier, an allogeneic transplant has a higher risk than an autologous. Of course, that can't be modified in certain conditions because some patients can't be cured with an auto transplant, and they do require an allogeneic. High-dose chemotherapy regimens, as I showed you, or high-intensity conditioning regimens versus lower conditioning regimens associated with a higher risk. And certain graft versus host prophylaxis regimens, particularly sirolimus-containing regimens, are certainly been associated with a higher risk of developing VOD. Now, before we turn to the VOD diagnostic criteria, I think it's important to note the various signs and symptoms of this disorder, as well as the events that lead to organ dysfunction. So in this slide, I sort of want to review the cascade of events, which really is the pathophysiology of VOD, that ultimately result in liver dysfunction. And I think once you understand the pathophysiology, you'll have a better understanding of the clinical signs and symptoms of VOD. So the first part of the pathophysiology is damage to endothelial cells within the liver. And this sets up a cascade of damage and narrowing to the sinusoids in the liver, and that leads to sinusoidal blockage. Once you have blockage of the sinusoids within the liver, it leads to narrowing, and that narrowing ultimately leads to portal hypertension and a reduction in hepatic venous flow. It will move on to multi-organ dysfunction and particularly develop into hepatorenal syndrome. Now, if you understand the pathophysiology of the development of the portal hypertension and the hepatorenal syndrome, you could well understand the signs and symptoms associated with VOD, which is noted on the right of this slide. Weight gain, which is due to capillary leak and portal hypertension, enlarged liver. The enlarged liver may be associated with right upper quadrant pain. The blockage may lead to an elevated bilirubin, although as I'll show later, not everyone is icteric with VOD, can lead to elevated liver enzymes such as transaminases or alkaline phosphatase. And if there's a large capillary leak in the abdomen, it can lead to ascites. So these are the signs and symptoms with VOD, and they're all related to the pathophysiology of VOD developing in the liver. Now, this shows a suggested time frame of the development of VOD. Not every patient follows this timeline, but this is a common timeline. It shows you the development of VOD with signs and symptoms developing over a period of 3 weeks after the stem cell transplant that leads to multi-organ dysfunction, particularly affecting the kidneys and the lungs in large part, but other organs such as cardiac failure and central nervous system dysfunction are also common organs that become affected as this disease becomes progressive. Now, historically, we had relied on 2 criteria for making the diagnosis of VOD. The McDonald criteria, otherwise known as the modified Seattle, and the Jones criteria, otherwise known as the Baltimore criteria, in large part because George McDonald and Rick Jones developed these criteria while working in Seattle, Baltimore, respectively. And you notice the criteria are similar but not the same. So for instance, in the McDonald's criteria, it's not required to have hyperbilirubinemia. It can be one of the three factors. You need two to meet the criteria. But it has to be within 20 days of the transplant. In the Jones criteria, you have to have developed these symptoms by day 21, but you also have to have hyperbilirubinemia. So patients who are icteric, who have VOD, would never meet the criteria of the Jones criteria. But if you develop these symptoms and signs within 21 days and you were hyperbilirubinemia, you would need two of these three criteria to meet the Baltimore criteria. Now, if you look at those criteria, which are now close to 35 to 40 years old, there are some limitations. So one, the obvious one, is we know that patients develop VOD after day 21 in transplant, and neither of those definitions would allow that diagnosis to be made. The Jones criteria requires hyperbilirubinemia, but we know their patients can be anicteric, meaning no hyperbilirubinemia, and they still have VOD. And more recently, over the last decade or so, we've had other descriptions of organ dysfunction that are not included in those criteria. And over the last 10 years as well, we've had new imaging capabilities, particularly ultrasound and Doppler and elastography of the liver, that also enhance our ability to make the diagnosis. So here's an example of ultrasound, one of the pathognomonic signs on ultrasound, which doesn't occur all the time, but does occur many of the times, is reversal of hepatic portal flow due to the obstruction I mentioned earlier when discussing the pathophysiology. So a group of us experts reviewed the field, had many discussions over a year and a half, and came up with a more contemporary and more user-friendly revised diagnosis criteria based on the limitations I mentioned earlier. And these were just recently published, as I mentioned, in the British Journal of Hematology. And that means that any two of the following 7 criteria would meet the diagnosis of VOD. Elevated bilirubin, which is greater than the upper institutional limits. Weight gain, greater than 5% of baseline. Criteria that we've now become familiar with that happens in a number of patients, which is they develop refractory thrombocytopenia and don't respond to excessive platelet transfusions, is a new criteria. Hepatomegaly for age or increased size over pre-transplant. Right upper quadrant pain, which was in the other criteria. Ascites both by physical exam or by imaging. And then the last, which I mentioned just a second ago, reversal of portal venous flow by Doppler ultrasound. Now, not that we recommend it, but there are patients for a variety of reasons where the treating physicians proceed with an hepatic biopsy. And if that biopsy comes back consistent with VOD, then that would be enough to make the diagnosis. Or if they had a reason to measure portal venous wedge pressure, which again we're not recommending, but if it happens to be done, that also would be a single criteria for diagnosing VOD. Now again, all of these criteria need to be probably or definitively related to VOD or SOS and not related to other criteria. And then obviously patients who, for whatever reason, come into transplant with an already elevated bilirubin, this cannot be used as a criteria after transplant since they already had an elevated bilirubin. So now let's discuss the advantages of what I just described as the new revised and more contemporary diagnostic criteria. So as you remember from the older slides, A VOD had to be diagnosed within the first 21 or 20 days, depending on the Seattle or Baltimore criteria, respectively. In these revised criteria, there's no limit on timing of making the diagnosis of VOD. As I mentioned earlier, not all patients, and particularly children, don't always manifest hyperbilirubinemia, so now this new revised criteria allows anecteric cases. As I mentioned, one of the new criteria are platelet refractoriness that occurs during the pathophysiology of VOD. This isn't common in children, and so now this added criteria improves your ability to make the diagnosis. We now harmonize the weight gain. As you remember, in the Seattle criteria is 5%, in the Baltimore was 2%. Now we've harmonized it into 5% above baseline. We've now added the ability to use diagnostic imaging such as ultrasound to show hepatomegaly or ascites, and certainly with Doppler, reversal of blood flow within the liver. For the rare patients who end up having a liver biopsy, certainly a diagnosis of VOD on the biopsy would be a singular criteria. And also in those patients who rarely have hepatic wedge pressure measured, that also could be a single criteria. And lastly, now we've harmonized the pediatric and adult criteria all into one category. After diagnosing, characterizing disease severity is an important aspect of assessing the patient with VOD with symptoms. The severity of VOD is ultimately tied to a higher risk of mortality. But I have good news for you. We also have now developed a more accurate and modern tool for severity grading, which we'll explore shortly. First, let's look at the organ dysfunction that commonly occurs with VOD or SOS. So as I mentioned earlier, the main organs that are affected obviously are the liver, but the other major four organs are the lungs, the heart, the kidney, and the central nervous system, as manifested by hypoxia, congestive heart failure, AKI or acute injury, or encephalopathy, respectively. Now, how does the mortality compare with VOD with multi-organ dysfunction? In patients that have either acute kidney injury and or pulmonary dysfunction, the risk of dying is actually at 84%. It's quite high. Now, we don't even see that kind of risk with serious infection, engraftment syndrome, even with grade 3 acute graft versus host disease. The only diseases that compare in that range for mortality are grade 4 acute GVHD and idiopathic pneumonic syndrome, or IPS. Now, over the years, and this was published by the Seattle group back in 1993, that the higher the maximum mean serum bilirubin, the more severe the toxicity is going to be with VOD. The same is true with weight gain. So patients that have weight gain in the 2 to 4% range, you could see, have almost no toxicity from VOD. Patients who have mild to moderate weight gain, kind of up in the 4 to 6% range, have a moderate toxicity. But patients who have weight gain that starts to get above 8 to 10%, even up to 12%, they have a significant risk of developing severe toxicity. Now, the old standard grading system, which was developed by George McDonald again in 1993, which was useful at that time and was based on a database of over 1,500 patients from Seattle, had 3 gradings: mild, moderate, and severe. Now, severe was defined as signs and symptoms that did not normalize by day 100. So you could see that patients who are day plus 21 and not already at day 100, it would be hard to define whether they ultimately will have severe VOD by this definition, or patients that die retrospectively then have severe VOD. In mild VOD were no treatment of fluid retention, no analgesia, complete reversal signs and symptoms with no therapy. Again, a very hard diagnosis to make early on, could only be made in large part retrospectively. And moderate sort of fits in between all of them. So at the time, it was a useful set of definitions that were useful for the data set that was being analyzed in Seattle. But today, this is not as useful. And so we've devised a more contemporary definition. Before I go to that, I do want to mention, I think, one of the best publications on this subject by Scott Bierman and colleagues in Seattle, and that is a retrospective review that they did that looked at the day post-transplant, which is outlined in these nomograms here. You can see it starts from day -1 to +1 all the way up on the upper left to the one all the way on the down on the right, which is day 14 to day 16 post-transplant. That if you know what the serum bilirubin and what the weight gain is, this nomogram will tell you between 30% and 60% what the risk is for developing severe VOD. It's a very useful nomogram, and we use it all the time, and I suggest that you actually use this. But that was based on the old definition of severe grading of VOD. Now, the limitation of this is it doesn't include target organ grading. The definitions of mild and moderate are a little bit nebulous. Severe grading depends on resolution before day 100, and many of it is required to be done in a retrospective fashion instead of on that particular day when you would like to make the grading decision. Now, if you refer to the current NCI CTCAE definition of grading for VOD, they have this grading system. You can see here it covers, for grade 2, for an example, a moderately elevated bilirubin with mild interventions. Grade 4 is life-threatening consequences requiring either ventilatory support, dialysis, plasmapheresis, peritoneal drainage, and so on. But it's not very organ-specific, and it's helpful, but it doesn't take into account the entire syndrome of organs that are affected and the degree that they're affected in patients who develop VOD post bone marrow transplant. Now, what are the common either signs, symptoms, or organs that are affected by VOD? So we have 3 liver signs and symptoms: elevated bilirubin, elevated transaminases, and portal hypertension. We have acute kidney injury or renal changes in creatinine. We have weight gain compared to baseline. We have lung toxicity is manifested by hypoxia. CNS toxicity is manifested by encephalopathy. Cardiac disease is manifested by failure. And then ascites, which is subdivided between symptoms and or intervention procedures. So after much discussion, we decided to use what already existed in the NCI CTCAE grading system for each of those 9 categories. So as shown here, we have bilirubin, transaminases, and portal hypertension, then weight gain and ascites, and taking exactly from the CTCAE 5.0 classification, you can make the designation of the grade of VOD if any of those are abnormal. And the way the grading system is set up is that it's the grade where the maximum grade toxicity exists. Also noted on here, similar to the old system, grade 0 are patients who don't have SOS or VOD, and grade 5 are those that have death. And these are probably or directly adverse events related to VOD or SOS. And similarly for the other 4 categories, you can see here for acute kidney injury is based on the creatinine changes of upper limits of normal at each institution. Pulmonary is based on hypoxia, cardiac disease on cardiac failure, and CNS disease on encephalopathy. And these are the same CTCAE criteria. And again, the grade is defined by the maximal organ grade of toxicity. So as an example, if the patient had a creatinine that was around 1.5 upper normal limits, but had decreased oxygen saturation and required supplemental oxygen, because the pulmonary toxicity is greater than the kidney injury, the maximal grade in this patient would be a grade 2. Now, what are the advantages of this system? So first of all, it's using a well-established, accepted organ-specific toxicity criteria, the CTCAE. It's now organ-specific. It's obviously contemporary. As the CTCAE is upgraded, when the 6th and then 7, 8, 9, 10, etc. is upgraded, those will be the criteria that will be used for the diagnosis and, for the grading of VOD. And this system doesn't need to be revised going forward. It will just be revised whenever the CTCAE system is revised. This grading will then allow investigators to compare protocols and publications regarding VOD or SOS if everyone is uniformly using the same grading system. And this will not require any new validations because these gradings are already accepted in the field. Now, once we've established VOD as a diagnosis and determined disease severity, the next step is deciding on treatment. Let's explore treatment options. So the main treatment landscape is the use of Defibrotide, which is an FDA-approved drug for adults and children with hepatic VOD with either renal or pulmonary dysfunction, and that has to be used in conjunction with supportive care, which includes diuresis, fluid and electrolyte restrictions and balance, sometimes AKI support as in hemofiltration or hemodialysis, occasionally paracentesis, and many times mechanical ventilation support. Now, historically, anticoagulant or thrombolytic therapies have been tried based on the pathophysiology that the sinusoidal narrowing is due to microocclusions that are occurring in very small venules within the liver, and these are leading to microclot formation. However, the use of heparin and or TPA in patients with VOD has resulted in life-threatening hemorrhage and has not shown a significant improvement in the overall outcome, and are generally not recommended anymore, particularly in patients with either pulmonary and or renal dysfunction. On very rare occasions, liver transplant has proven to be beneficial, but this is very rarely employed. There are some patients who have very bad portal hypertension, and despite receiving the above recommended supportive care, as well as Defibrotide, have progressive ascites and worsening portal systemic shunting, and they require a transjugular intrahepatic portal systemic shunt, otherwise known as TIPS. So Defibrotide is derived from porcine intestine. It's a complex of single-stranded oligodeoxyribonucleotides, and it's a sodium salt complex. In one study that was published by Paul Richardson in Blood in 2016, patients who met the Baltimore criteria by day 21 and also had either renal and or pulmonary dysfunction were randomized to Defibrotide for a duration of approximately 22 days, but could get the drug upwards to 60 days. And they were compared to a historical control of patients with VOD that had been treated earlier but didn't receive Defibrotide. This ended up being a 4-to-1 randomization, so you can see the evaluable patients were treated for a minimum of 21 days, and the evaluable historical control arm, which there were about 1/4 of the patients, they served as the control. Now, when you compare the survival in the Defibrotide patients at day 100, you can see there was a significant improvement in survival. In the Defibrotide treated patients, a significant improvement in the complete remission rate on day 100, but no significant increase in the hemorrhagic risk of adverse events with Defibrotide versus the historical group treated with supportive care. In a large treatment investigational new drug study, or T-IND, 101 centers contributed 1,154 patients who received 1 or greater doses of Defibrotide at the standard doses of 6.25 milligram per kilo Q6 hours for at least 21 days. And there's data on 1,000 patients who reached at least day 100. And you can see off to the right the survival rate in a high-risk group of patients when you take all comers by day 100 was about 60%, significantly better than historical controls. And even patients who had multi-organ dysfunction, the black curve there, they had a day 100 survival rate in the mid-50s, and patients who were without multi-organ system disease, they actually had an even better day 100 survival rate that ranged at about 70%. Now, slightly improved results with Defibrotide in pediatric transplant recipients. You can see here the results by day 100 in all patients showed about a 70% overall survival rate, and it's down to about 55-60% in adult patients who received Defibrotide in this T-IND study, with a range of patients without multi-organ dysfunction doing better at 60%, and those with multi-organ dysfunction probably at between 40 and 45% overall survival. So one of the things we observed over the last several years is that early treatment with Defibrotide in patients diagnosed with VOD has an important impact on their mortality. As shown in these Kaplan-Meier curves, in the treatment IND study that I mentioned earlier, patients who had the Defibrotide started within 2 days of making the diagnosis had a 57% chance of being alive at day 100, versus patients who didn't have their Defibrotide started until 3 days or even later after that only had a 20% chance of being alive on day 100. So this clearly shows that making an early diagnosis and instituting a drug that's already approved in the disease early will have a significant impact on improving survival in patients with VOD post-hematopoietic stem cell transplant. And this just shows you in a more graphic form in terms of the timing of the treatment from day 1 through day 14, and you can see that patients treated, both adult and pediatric, who were treated within the first 1 or 2 days of the diagnosis being made had a much better survival rate than those who the treatment was delayed even as late as 7 or 14 days from the time of diagnosis. So shown here is the safety profile in Defibrotide. This again was in the large T-IND study. And in general, Defibrotide was very well tolerated with very manageable toxicity. There were no safety signals that were observed. Now, as you can see from this table, the risk of some adverse events were higher, as you would expect, in patients who had multi-organ dysfunction, as defined by the MOD subgroup, versus the no MOD. So as an example, hypotension was more common, almost 17% in the patients with multi-organ dysfunction versus those without that only had 9%. And at the bottom of the table, you can see some of them were equal between the two groups, but overall, Defibrotide was very generally well tolerated with very manageable toxicity. Now, the dosing is pretty straightforward with Defibrotide. As I mentioned earlier, it's 6.25 milligrams. Q6 hours is a 2-hour infusion. This drug, because of the way it works, should not be given with systemic anticoagulation or systemic fibrinolytic therapy. It's going to raise the risk of bleeding if you're giving this drug with systemic anticoagulation or fibrinolytic therapy. It can rarely but can cause a hypersensitivity or allergic reaction depending on the grade of it. For grade 4, we certainly want to permanently discontinue the drug. For others grades, if they return back down to a lower grade, it could be potentially started again. Again, depending on the grade of bleeding, one may want to stop the Defibrotide until the bleeding has gotten under control and is a much lower grade, and then restart again. And then for patients who are getting invasive procedures, particularly going to the operating room, because this drug has such a short half-life and has to be given every 6 hours, if you hold the drug for greater than 2 hours, most of the effect is gone, and these patients then can go on and get their procedures done with very little risk of having any bleeding. Now, in a meta-analysis that was just presented in December 2019 at the American Society of Hematology meeting, when Defibrotide is given in a non-VOD setting, the risk of developing bleeding is so low, it's shown on these slides. You can see here that the risk is about 1% of having serious bleeding when IV Defibrotide is given in a non-VOD setting, which now we're seeing more investigations of this drug in those settings. And lastly, in terms of the pharmacoeconomic assessment, this is a nice slide. You can see here on this slide the cost of care to patients, and it's shown here broken out by adult and pediatric patients. And this is in a 100-patient cohort that was published in the Journal of Medical Economics by Venestra et al. And you can see here that the cost of care, whether patients got Defibrotide or not, is almost identical. And the additional cost by giving Defibrotide in both children and adults is a very negligible amount of money compared to the total cost that occurs during transplant. And we don't believe that this is a big factor in not wanting to give or withholding Defibrotide, and that it doesn't appear that it's adding more costs. So to summarize, I think what we've seen today is that contemporary and more versatile diagnostic criteria will allow for prompt diagnosis of VOD, which contrasts much more favorably with more historical, older, classic criteria. Similarly, I've tried to show you today that the revised, more novel and contemporary grading system represents an innovative and practical step forward that integrates an already well-established toxicity system, i.e. the NCI CTCAE system. And finally, we saw that facilitating the early identification and diagnosis of VOD will lead to more timely therapy with effective and already FDA-approved treatment and ultimately improve the survival in what historically has been a lethal disorder, as I mentioned earlier, an 84% historical mortality rate in patients post-transplant with VOD that either have pulmonary and or renal dysfunction. Thank you for joining me today. I hope you found this program interesting and useful for your practice. Good day.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KAS860. This activity is supported by an educational grant from Jazz Pharmaceuticals, Incorporated. This activity has been jointly provided by Medical Learning Institute, Incorporated and PVI, Peer Review Institute for Medical Education.